Bismillahirrahmanirrahim. Today we discuss preoperative assessment. Careful preoperative assessment is essential to achieve good surgical outcome. Same principle is applied to the emergency and elective conditions. The only difference when the emergency condition is the preoperative assessment is rapid and compromised. But if the condition is elective, the preoperative assessment is take 2 to 3 weeks to prepare patient. When making decision to operate, the risk and potential benefit of surgery should be weighed against those of alternative or no treatment. The important things why we prepare patient for surgery. We prepare patient for surgery is essential to prepare patient for surgery and identify comorbid condition, estimate and minimize preoperative risk by optimizing the patient physical condition. So these three purposes to prepare patient for surgery. The majority of preoperative assessment for elective surgery take place in preoperative assessment 1 to 2 weeks before surgery and culminate in admission immediately prior to or at the morning of surgery. The first priority to establish the severity and extent of the condition requiring surgery by employing appropriate imaging and other investigation. For example, when we want to operate on the thyroid goiter, you should examine both recurrent laryngeal nerve are functional before surgery, because the damage to this nerve is recognized complication of this type of operation. On the other hand, malignant conditions require appropriate staging to establish the disease extent. The second objective of preoperative assessment is to identify comorbid condition, i.e. patient illness before surgery, medical problem before surgery, through careful clinical assessment and through thorough optimization and minimize preoperative risk. In the emergency situation, this process is condensed because there is no time to prepare patient 1 to 2 weeks in elective surgery. In emergency, the time is limited, so the surgeon must determine which intervention will optimize the patient condition while avoiding deterioration due to unnecessary delay. Okay? We prepare patient by taking a thorough history. The important one and first thing is cardiovascular system. The severity of cardiovascular system should be assessed. Ask about angina, previous myocardial infarction, indicates significant coronary artery disease, although procedure like bypass grafting, angioplasty, coronary artery stenting may ameliorate their associated risk, i.e. they decrease the risk of these cases during surgery. Exertional dyspnea, orthopnea, and paroxysmal nocturnal dyspnea may indicate left ventricular failure, while significant dependent ankle edema could signify the right-sided heart failure. Clinical examination should detect arrhythmias, irregular pulse, carotid artery, or heart murmur, hypertension, and sign of cardiac failure. Antiplatelet should be asked about drugs that taking patient with cardiac problem should ask about drugs that who take the drug. What is the drug you take? Antiplatelet agent, anticoagulant are widely prescribed in general population. I may need to be stopped or modified before surgery. Okay. The second system, respiratory system. In patient with asthma, chronic obstructive pulmonary disease, COPD or fibrotic lung disease, purulent sputum may indicate an infective exacerbation in asthmatic previous upper respiratory tract infection, and hospital admission as well as steroid dependence indicates severe disease. Functional respiratory reserve is best assessed by exercise tolerance. For example, how far patient can walk on the flat, up an incline, or how many stairs they can be climbed before needing to rest because of shortness of breath. This question give idea about the significance of the respiratory problem before surgery. Significant dyspnea should be investigated with pulmonary function test. Patient with feature of acute viral respiratory illness should have surgery postponed where possible. If the operation is elective, the operation is postponed if the patient have any acute respiratory illness. This is due to an increased risk of bronchospasm and susceptibility to post-operative bacterial pneumonia, which is compounded by effect of general anesthesia, which depress ciliary activity, reducing the clearance of secretion and pathogen. All these make any acute respiratory illness should be postponed surgery. The third thing, should ask about smoking. Why we should ask about smoking? The patient should be encouraged to quit smoking, particularly once the decision to operate has been made. Many patients have not able to stop smoking, okay, because it is very difficult because the patient have dependency on the smoking, so it is very difficult to have smoke. Why your patient should have smoking cessation? Why? The benefit of cessation of the smoking is reduced airway hyperactivity, bronchospasm, and the stop smoking will be reduced sputum production, reduce the risk of atelectasis, improve ciliary function, result in increased sputum clearance, helping to protect against infection, and reduce carboxyhemoglobin, so increase oxygen carrying capacity of the blood. The third benefit of cessation of smoking is reduced nicotine-related systemic and coronary vasoconstriction. The fourth thing, we should ask about alcoholism before surgery, because there is in chronic alcohol abuse, the liver enzyme will be induced, so increase hepatic drug metabolism. Consequently, increased doses of hepatically metabolized drug, especially anesthetic drug, are required to achieve therapeutic effect. So in chronic alcohol abuse, the dose of anesthesia will be increases. Conversely, in acute alcoholic intoxication, reduced anesthetic doses are required. In addition, the risk of aspiration pneumonia should be anticipated and preventive measures taken. In patients with significant alcohol history, the risk of the alcohol-related liver and cardiac disease and coagulopathy should be anticipated. Other thing, nutritional status. All patients should have their weight and height measures the body mass index before surgery. It is important to look for signs of malnutrition, such as low body mass index, body weight less than 90% predicted, or more than 20% weight loss, hypoproteinemia and hypoalbuminemia, as they have all been related to an increased rate of post-operative complication, especially delayed wound healing and wound infection and pulmonary complication, as well as delayed anastomosis and wound healing. For this reason, it is important to treat malnutrition preoperative if time permit. If the surgery not emergency, so should treat the malnutrition before surgery. Other thing, obesity. Obese patient has had an increased risk for surgery and anesthesia, and special equipment may be required. For example, special couch obese patient at risk of major associated comorbidity, for example, diabetes, obstructive sleep apnea, degenerative joint disease, cardiovascular disease. In practice, the majority of the patient cannot lose weight without support and referral to the GP and dietitian for weight loss programs, including supervised exercise, may be beneficial. Other things you should ask about drug therapy. What is the drug that taken by patient before surgery? It is important to ask about long steroid therapy. Long steroid therapy or steroid abuse lead to the adrenal insufficiency. So surgery need more adrenal secretion because surgery considered as a stress. So the steroid hormone is one of the most important hormone that is encountered for metabolic response to the trauma or surgery. If the patient take steroid, lead to the adrenal insufficiency, and when the surgery occur, need more steroid. And the patient have adrenal insufficiency may lead to adrenal crisis, which is important complication after surgery. So an increased steroid dose is usually necessary to counter surgical stress for all but minor surgery, not need to increase the dose of steroid. High dose 100 milligram hydrocortisone every 6 hours may be needed if the risk of hypoadrenalism is compounded further by post-operative complication and include infection. Signs of hypoadrenalism include hypotension, shock, hyponatremia, and hyperkalemia. Other drugs should be asked about antiplatelet therapy and anticoagulant. Antiplatelet with aspirin, clopidogrel, and dipyridamole is common. The risk of thromboembolic event, particularly myocardial infarction, if antiplatelet therapy withdrawn, it should be weighed against the risk of surgical hemorrhage if the treatment is continued. Where possible, surgery should be postponed and antiplatelet agent withdrawn only after consultation with the cardiologist or vascular surgeon. Anticoagulation with warfarin, commonly for prevention of embolic event in AF and for treatment of deep vein thrombosis and pulmonary embolism, is also frequently encountered the risk of thromboembolic event. So this aspirin should be stopped for 1 to 14 days before surgery. With anticoagulant suspension has to be balanced against the risk of bleeding of anticoagulated patient undergoing surgery. The use of bridging anticoagulation should be considered. Also should ask about oral contraceptive hormones. Long use of oral contraceptive is associated with the deep vein thrombosis. So should stop the oral contraceptives before elective surgery for 4 to 6 weeks before surgery. Psychiatric drugs, tricyclic antidepressant and phenothiazine can both cause hypotension, and tricyclic associated with the increased risk of arrhythmia. In case of phenothiazine, the risk of stopping this medication is more than potential benefit, but the anesthetist should be aware of potential complication. It is not essential that tricyclic antidepressant to be stopped preoperatively, but the anesthetist should be alerted. Lithium, which is psychiatric drug, should be stopped 24 hours prior to surgery, as it is mimic sodium that potentiates the action of neuromuscular blocking agent that given by anesthesia. Monoamine oxidase inhibitor interact with the opiate and vasopressor agent with the potential neurological and cardiovascular complication. Ideally, they should be stopped 2 to 3 weeks prior to surgery. Other things should be ask the patient before surgery about any allergy. Common example of the surgical practice include antibiotic, iodine, adhesive dressing, and latex of the gloves. Full-blown anaphylactic reaction to the latex are rare, but some degree of latex sensitivity is common. Special care has to be taken to clear the patient environment of latex for those with the severe allergy response, as it is common in gloves and other surgical and anesthetic equipment. As about pregnancy, before elective surgery should be avoided in the first and third trimester of the pregnancy. The risk of miscarriage and potential teratogenicity is high when the operation is carried out in the first trimester, and this is usually encountered in relation to surgery for acute abdomen at this stage. Third trimester surgery is associated with a significant maternal risk and premature labor. If surgery is necessary, it is best undertaken in the second trimester. Previous operation and anesthesia. Detail of previous anesthesia include complication, side effect of drugs, and reaction should be sought and should be alert the anesthetist to potential anesthetic challenging include difficult endotracheal intubation. Suppose patient have previous surgery and have difficult intubation. So should alert the anesthetist about this complication before that surgery. Previous major anesthetic complication or family history about the complication, possibility of rare inherited abnormalities like choline apnea, which is pseudocholine esterase deficiency, that called choline apnea, and is characterized by prolonged apnea after surgery, requiring prolonged ventilation in response to short-acting depolarizing muscle relaxant, for example, choline. Malignant hyperpyrexia is inherited autosomal dominant condition characterized by life-threatening hyperpyrexia that occur during or after short time of surgery. What are the investigations that preoperatively done to the patient? Preoperative investigations are undertaken to assess fitness of anesthetic and identify problem amenable to correction prior to surgery. Preoperative investigation commonly include hematological, biochemical, radiological, or cardiovascular and respiratory tests. Regarding hematology, a full blood count, major patient undergoing surgery will have preoperative full blood count because the oxygen carrying capacity of the blood depends on the hemoglobin concentration. Its importance, but the platelet and white cell count are also important consideration in terms of hemostatic capacity. Any patient undergoing surgery, however, anemia should be corrected preoperative to optimize oxygen delivery to the tissue. Preoperative blood transfusion should only be considered for hemoglobin concentration below 8 grams per deciliter. So if the patient have 9 grams per deciliter, have no indication for blood transfusion. Surgery with potential for significant blood loss should have a full blood count, as should those with the sign or symptom of anemia. Patient with significant cardiorespiratory disease that may compromise oxygen delivery to the tissue, and those with the over or suspected blood loss, for example, gastrointestinal tract symptom. An abnormally elevated white cell may indicate infection or hematological disease and should be investigated preoperatively. Thrombocytopenia, an increased risk of thromboembolism, and prophylactic measure should be taken. Thrombocytopenia, which is mean less platelet, may need to be corrected to reduce the risk of bleeding. The UK blood transfusion service recommend transfusion to the platelet if the count is less than 50,000 of 10/9 per liter for lumbar puncture, epidural anesthesia, endoscopy with biopsy, and every surgery. Coagulation screen. The indication for coagulation screen, i.e. Measurements of bleeding time, prothrombin time, or PTT includes suspected abnormal clotting, anticoagulation therapy, and consideration of epidural anesthesia. When DIC is suspected, such as sepsis, fibrinogen degradation product, and D-dimer should be measured. The surgical implication for selected disorder of coagulation are considered below. Regarding the urea and electrolyte measurement, the analysis of urea and electrolyte is not necessary in young patient. Healthy patient need no measurement of urea and electrolyte. Elderly patient and those presenting for major surgery, as well as the renal dysfunction, cardiovascular disease, fluid balance problem include dehydration, and patient on diuretic therapy and any drug therapy that may affect electrolyte balance or renal function should have a routine blood urea and electrolyte analysis. Unless this indication, there is no need to measure the urea and electrolyte in the young healthy person that want to be surgery. Liver function test. All patients with non-liver disease, significant alcohol consumption, or sign of liver disease should have liver function test. Liver function test mean measurement of bilirubin, direct, indirect, measurements of the liver enzymes, measurement of the prothrombin time. This is mean liver function test. Cardiac investigation. ECG is very limited value in predicting the risk of ischemic event and generally should only be performed in elderly over 65 years to detect occult rhythm disorder or sign of previous cardiac event. In younger patient, ECG should be restricted to those with the sign of cardiovascular disease and those with the risk factor for ischemic heart disease. Routine X-ray, chest X-ray should only be performed in consent of cardiovascular assessment where congestive heart failure is suspected. Echocardiography is used to assess cardiac function, like left ventricular ejection fraction in particular, may be indicated prior to major surgery and in patients who suspected to have valvular disease and heart failure. Cardiopulmonary exercise test is dynamic test for cardiopulmonary reserve that is used selectively to help select patients for high-risk surgery such as thoracic, vascular, cardiac surgery. Respiratory investigation. Patient with purulent sputum suspected to have a chest infection and should have sputum cultures. Antibiotic sensitivity test. Preoperative chest X-ray is useful baseline in patient with none or suspected pulmonary disease. Maybe demonstrate consolidation, atelectasis, pleural effusion. So routine chest X-ray is not indicated if healthy patient. Pulmonary function tests are useful to gauge severity and reversibility of the obstructive component of respiratory disease. The last thing in the preoperative assessment should take informed consent. معناها الموافقة. Informed consent is central to practice of surgery and has to be obtained for surgical procedure. Any surgical procedure should take informed consent from the patient. Other treatment modality, investigations, sometimes investigation need informed consent, and screening test and prior to patient participation in research. Even in research حتى بالبحث should have a consent.